Great. I'd like to begin by making acknowledgement of country and paying my respects to the Aboriginal elders, past, present and emerging, and note that I'm on the lands of the Wurundjeri people of the Kulin Nation, and recognising that we're all on various lands across the country, and recognise that these lands were never ceded. I'm delighted to be able to bring you our third webinar for the Deliver series. So, these webinar series are really about, engaging with people across the sector to learn more about ways that we can optimise home-based care for older people, and in particular, how we can look at different solutions such as digital tools for supporting that optimisation. And earlier this year, I was at the Digital Health Festival and had the pleasure of seeing Dr. Shannon Nott give a really engaging presentation, and it resonated with me that what he's doing in New South Wales is really, there's a lot that we can learn that would really support what we want to achieve in the Deliver program. So thank you, Shannon, for responding to my emails and accepting the invitation to come and speak to our team. As I've mentioned, we are a team of health service representatives, as well as people from the academic sector. And so we're all bringing slightly different backgrounds to this, but I know that you span both those areas quite well. So we're really privileged to have you here. And so for everyone in the room, Dr. Shannon Nott is the Rural Director of Medical Services for Western New South Wales Local Health District. And he oversees more than sort of 35 rural and remote hospitals with a multi-purpose service across that region. Shannon is an expert in virtual care and led the implementation of the region's vCare Critical Care Hub. He's also led the creation of Australia's first Virtual Rural Generalist Service, as well as the development of a virtual clinical service, pharmacy clinical service for rural communities. He's also the clinical lead for the Virtual Care Community of Practice for New South Wales, and is the Virtual Care Medical Advisor for New South Wales Health. And on top of all that, he's also supported the progression of research in both rural and remote communities and virtual care, and has led a lot of large mixed method studies in real world virtual care projects. So we're really excited to hear your presentation today, Shannon, and it's titled Embedding Virtual into Regional Care. So I'll let you share your screen.
Thank you very much, Kate, and thanks everybody for joining us. I'll hopefully be able to share my screen, and I'm just checking that you can see the PowerPoint, and people give us a thumbs up if you can see that. I see some nods. Thank you. Before I begin as well, I'd just like to acknowledge that I'm coming to you from Wiradjuri land, and certainly recognise and acknowledge the traditional owners of the land on which I'm beaming to you from today, and acknowledge the important role that we within health play to work alongside to empower communities and address some of the significant inequities that exist for Aboriginal and Torres Strait Islander peoples across our country. So as Kate said, I am the Rural Director of Medical Services for Western New South Wales Local Health District, and today I'm going to run through a few cases around models of care that we've been able to embed to be able to address some of the unique challenges that we have across our region. For those of you that might not, I believe most, if not all of you, are from Victoria, so some of you might not be familiar with the region I'm talking about today. But Western New South Wales is a region that spans over 250,000 square kilometres. That's not quite the size of Germany, but certainly it is a significantly sized region in New South Wales. We have 38 communities of varying sizes, from larger regional hubs, places like Dubbo, Orange and Bathurst, through to incredibly remote Aboriginal communities, places like Kaduga and Gonia, and everything in between. And as many of you would well know, our region, like many rural and remote regions, are susceptible to pressures around geography, the challenges associated with vulnerable communities, particularly communities that basically in nearly all markers of socioeconomic status fall behind the rest of the state. Obviously, the inequities that exist within, from a health outcomes perspective, are incredibly evident across our region. Generally speaking, most markers of health outcome for people across our region are lower compared with state and national averages. We're also restricted by some of the challenges associated with geography. Our staff travel approximately 11 million kilometres a year delivering care to our rural and remote communities, and that pales in comparison to the distances that our patients travel to access care, which, depending on models used, it can be triple to about 7 times as much as that. But really, the reality is that we don't know how much patients are travelling to access care. And so, like a lot of rural and remote regions of Australia and the globe, we've had to look at different ways of working. And like a lot of rural and remote areas, utilisation of technology has become a core part and business as usual for us. And so whilst we all go to conferences and everyone talks about how COVID has transformed the way in which we deliver care, and it certainly has, this was just an ongoing piece of evolution that we've had to do for many, many years. And so if I went back to that first slide, the picture I had when we first started was a gentleman called Alfred Traeger, and I'm not sure whether people have heard of who Alfred Traeger is, but most people have heard of the Royal Flying Doctors Service. And so when the Reverend John Flynn started the Royal Flying Doctors Service, they realised that they were only as good as the technology allowed them to be able to be understand that an emergency was needed in a rural town. And in the early 1900s, most rural towns weren't on telegraph wires. And so people still would have to travel potentially days to the nearest place with a telegram wire to then Morse code to a larger centre to request for help. And so Alfred Traeger was actually a German engineer involved in the First World War, but he worked with John Flynn to what is well known as sort of developing systems that gave rural communities their voice. And so he actually developed the pedal radiograph. And if I'll step back quickly just so you can see that bottom picture there is actually Traeger using the pedal radiograph. So they would pedal as a little generator there, and they would be able to send, in this machine, it's actually this is probably a late 1920s or early 1930s machine, but in this machine, they'll be able to talk like a radio, like a UHF radio these days. The original version he had was actually a pedal radiograph, which actually allowed them to send Morse code messages to request help from RFDS. And so I always talk about that because it just puts into context that telehealth is not a new thing for rural and remote areas. We just didn't call it telehealth or virtual care. And so we have been refining in Australia and indeed many places around the world the way in which we utilise technology to deliver care for a very long period of time. Actually, as a bit of, because we've got a bit of time today, a bit of trivia. Does anyone know what the first message on the telephone was? You know what, Thomas Edison?
Right.
So he actually said to his offsider, I need you now. He actually had spilt battery acid on himself and had quite severe battery acid burns. Anyway, his assistant came across and delivered first aid. And so I jokingly say that that's the first time telehealth was invented. It was actually the first phone call was used for a health request. So it's just one of those things that I think we don't think of enough, but really the utilisation of technology to be able to cross different distances has been very much a part of rural and remote healthcare. So I'm going to start with a couple of cases and hopefully pull it all together at the end. One case is the Virtual Clinical Pharmacy Service, which we implemented in Western New South Wales. So this was part of a Translational Research Grant, which I had the pleasure of being Chief Investigator for. And so part of that grant actually allowed us to design, implement, and evaluate the service. And for those of you familiar with small rural hospitals, nearly every rural hospital, small rural hospital in Australia does not have access to clinical pharmacists to support medication management, medication education, and support medication choices. If I compare that to larger, certainly tertiary hospitals, if you were to be admitted into any one of the Royal whatever hospital in Australia, you would almost uniformly have a pharmacist see you during your admission. Medication misadventure is one of those key components that is synonymous with avoidable hospital-related harm. So much so that the World Health Organization actually made it one of the priority areas in recent times, and it actually equates for a significant proportion of hospital or related harm to patients. It's just so hard to quantify that reports vary quite significantly. And when the WHO actually looked at medication harm and avoidable harm, it suggested quite a number of interventions, all of which have been proven through peer-reviewed literature that pharmacists are probably best placed to implement. So things like best possible medication histories, medication reconciliations, medication chart reviews, medication education, and clinical handover. And so what we did when we were developing the service is what we looked at what is best practice in regards to medication management through the literature, and mapped where we could actually deliver that from a virtual service. And essentially most aspects of medication intervention could be done and delivered virtually. And in fact, most of the clinical pharmacists' key roles and responsibilities within the hospital can be placed into a virtual environment, with the exception of dispensing. And so what we built in is, for all of our small rural and remote sites, we developed a virtual pharmacy model that was based around pharmacy best practice, and allowed our pharmacists to beam in to the bedside of patients to be able to support the use and the education for patients and also staff of medications. That service was able to do quite a number of things for us. It improved significantly our compliance with national safety and quality standards across the board, so much so that when we went through accreditation, instead of having quite a number of not mets prior to this service, or areas to improve from the standard relating to medication safety, we actually passed without any requirements to change anything. And so much so, the evaluators were so impressed by the service, they actually mentioned within the reports that this should be something that's actually implemented across rural and remote hospitals. Patient outcomes, I'll run through in a little bit as well. We looked at patient acceptability and staff acceptability and the detection of medication-related harm. So I won't run through all of the findings, but some of the areas that we know through literature that actually improve medication safety, we measured. And so when you look at best possible medication history, that increased by 33-fold with the implementation of this service. Admission medication reconciliation increased 11-fold, and discharge reconciliation increased 4-fold. We also detected almost 2 medication or potentially moderate to high risk medication errors per patient. And the pharmacists were able to intervene with an uptake of interventions in terms of suggested changes by the pharmacist, an uptake of over 80% by the doctors that they were working with. Patients found the service incredibly rewarding. They found it an incredible value add to their care, and many patients reported better knowledge of their medications. Some of the areas that we weren't powered to find was around what changes in terms of medication error, because they aren't well articulated in our facilities. Because if you think about medication error, unless you're giving a drug that has an immediate adverse effect, most medication errors happen when people get wrong drug or wrong dose of drug. And most of the time when you give the wrong dose, the presentation is not overtly clear that it's medication related. It might be someone that's elderly that has had a fall or just feels a little bit off. It's not always picked up that that was a medication error. So our baseline systems around understanding medication error were not particularly sophisticated enough. And given the numbers of patients that we put through the service, we weren't powered enough to find any small changes because the reporting of medication error was quite low prior to us implementing this service. The next case that I wanted to share with you is the Virtual Rural Generalist Service. And so this service is very much an extension of the pedal radiograph that I talked to you about with Alfred Traeger and John Flynn, where people where they couldn't access doctors would be able to phone in or Morse code for help. And for us, across many of our small rural and remote towns, particularly with a declining GP population, and recognizing that general practitioners are the primary medical providers for these small country towns, we have found ourselves in an increasing situation where there are no doctors to support our little EDs and little inpatient units. And nurses, in lieu of that, were phoning around a bit ad hoc to people to try and get advice. There was a phone-based service that ran for nearly 10 years where there was limited oversight from a safety and quality perspective. They weren't utilizing contemporary notes. They weren't utilizing electronic systems and all the data available to them. And they certainly weren't speaking to patients. They were just getting a handover from the nurse. And so we saw increasing demand on that service. I saw significant clinical risk. And so we created or transformed that old phone-based service into the Virtual Rural Generalist Service, which is a fully integrated, fully digitalized service that utilizes video and audio first to directly speak with staff and patients around their care and be able to support patients in communities where there's no doctor, but also support doctors in communities where there might be only one of them. And we recognize that it's not acceptable for a doctor in a small country town to work 24/7, 365 days a year, nor is that type of model conducive to us being able to recruit people into the future, particularly given generational changes around expectations of work-life balance, safe working hours, the changes around expectations from the system as well around fatigue management. So as a fully integrated service, it's actually both virtual and face-to-face. And so one of the key components of this service is that the doctors do have to provide a face-to-face service in our region to the towns in which they have medical shortages. So it helps us, one, allow the doctors to understand local context, but also build rapport with the nursing staff that they work with virtually. It allows them to also help with education and training for the nursing staff so that they can refine examination techniques or do simulations. The service is very much integrated into our existing services on the ground and virtually. So this service and the virtual clinical pharmacy service actually work incredibly closely together. We recognise that there is obvious need to make sure that any health services provided is patient-centred, and so our aim is to try and treat people as close to home as possible. It's not a service designed to just put band-aids on and then send them down the road. So doing proactive care like ward rounds when there's no doctors on, being able to look at data and improvements. We're actually starting a service around follow-ups for patients that discharged against medical advice or did not wait to see a doctor in some of our towns, whether it's virtually or face-to-face. Safety and quality, the service is heavily monitored around safety and quality, looking at outcomes, all of the aspects that you would expect a contemporary health service to undertake against national or international safety and quality standards. This service has mapped our processes around incident management, around proactive case review, around supporting education of the system through morbidity and mortality meetings, refinement of clinical pathways and protocols. And certainly we're lucky we set this service up before COVID, and the service was able to scale rapidly to meet surging needs across our rural and remote hospitals, recognising that many GP practices during the first couple of years of the pandemic closed doors or refused to see patients face-to-face. So this service actually expanded quite significantly. You can also think about our geography and remoteness. Quite a number of doctors that we rely on for our remote towns are fly in, fly out doctors. Many of them are interstate. And so with lockdowns and border closures, we couldn't mobilize our workforce. And so this service needed to expand. And this service actually expanded over a 2-day period when the first rural and remote true outbreak happened in Australia, which happened in Western New South Wales across a number of our Aboriginal communities. And they expanded to do out of hospital care for COVID patients. So like many health systems, we were lucky we could turn this on, scale the service literally over a weekend. And so this service stood up, certainly the first in New South Wales, and I dare say the first in Australia, rural specific COVID care in the community team, and was able to manage that until we got to a time where there was such a need for a COVID specific team that we were able to recruit and utilize the processes that we developed in this team to develop a standalone COVID care in the community virtual team. I've covered this. A couple of things that people would be interested in is, why are you using rural generalists outside of specialists? And this is a point of contention when I speak to medical staff, is that, well, why GPs? GPs aren't specialists. They're not specialists in hospital case care. My response to them is that if a lot of clinicians will say face-to-face care is the gold standard. So if face-to-face care is the gold standard, and in rural and remote areas, rural generalists are the gold standard for face-to-face care in rural settings, why would you not make them the gold standard for virtual? Certainly there's ability, like any doctor that's working in a remote community, to be able to access specialty consults. But if I was to replace this service with specialists, I would have to have a FACEM arm. I'd have to have emergency specialists doing the ED work. I would have to have physicians doing the inpatient work. I would have to have geriatricians doing the residential aged care work. And then probably some specific GPs for some of the out-of-hospital care work. And so for us, the rural generalist doctors work very well because they understand context. And the hardest part from a telehealth perspective is obviously you need to be able to communicate well with staff, but also empathize with them around the context that they're in. Medicine and the management of patients is somewhat similar, but the context and the logistics of actually organizing the relevant management actually is a specific thing that sometimes is very difficult to teach. This data is a little bit old. I think this graph is over a year old. The service has gotten well over 80,000 consults since February 2020. It, in the last couple of years, is on average seeing 25,000 ad hoc consultations a year. And on top of that, between 5,000 and 10,000 proactive consults in terms of inpatients. We, during COVID, were lucky enough to get a research grant to look at evaluating VRGS. And we essentially, whilst this looks more complicated than what it should, looked at VRGS within the 4 quadrants of the quadruple aim. And so looking at patient outcomes, patient experience, clinician experience, as well as sort of sustainability and system-wide components. Some of the main findings for VRGS was that the outcomes of the service, when we compared them to face-to-face care, were similar for ED and inpatient care. There are some slight differences, but the actual percentage differences or the total number differences are quite small. So there were statistical differences in terms of those people that discharged against medical advice or did not wait. But the numbers were so small that the clinical relevance of that is unclear, because we have so many patients. There were so many things that were coming through as statistically significant with very, very small differences. In terms of raw numbers or percentage changes. I talked already about the throughput of the service. And when we looked at VRGS patients, they're more likely to be managed at the local hospital or in the community than those patients seen face-to-face. There was a higher transfer rate for face-to-face doctors. When you look at VRGS patients, they're also more likely to have a shorter stay in hospital. They're much more likely to have higher complexity in terms of inpatient care. And they are, as I said, more likely to have that discharge against medical advice, but also statistically were more likely to have unplanned readmission as well. Again, the unplanned readmission differences was less than 1%. When we look at the clinician experience of delivering virtual care, when we look at the VRGS doctors themselves, many of them felt that they wish they had this service in their face-to-face roles in rural remote towns. They felt that they were able to adequately assess patients within the limitations of technology, and that they were able to adequately make a positive impact for patients. When we look at site staff, so this is predominantly nurses, they feel that they're much better supported 24 hours a day than they are under a face-to-face model alone, and certainly more than the old telephone model that was being offered prior to VRGS. And in some communities, I was speaking with 2 sites earlier today that have requested, because of some challenging behaviours with staff, they've requested that this service supports them more because they feel like they're not getting enough support from some of their regular fly-in, fly-out doctors. From GP VMOs, so the doctors that the service supports, there are a lot of our sites across the 35 smaller rural and remote sites, about half of them, the doctors have demanded that this service is written into their contracts. So essentially they're happy to be first on call during the day, but from 6 p.m, they want to go second on call. So this service will see all of the patients as a first on call. and filter it so that the doctor's not woken up about the itchy toe or the sneeze that somebody's got late in the evening or early hours of the morning. Most of our face-to-face doctors are very happy to come in for really true emergencies, but where they can get a good night's sleep, remembering that they're not just working in the hospital, they also have often a full day worth of GP work. They've been really keen to have this service. And we've had a number of hospitals where we weren't able to staff them that are now being staffed because this service is supporting the doctors after hours. There are a few towns, it's probably 3 out of the 30 odd, where they either have enough medical staff and don't need this, or there is some real hesitance from the local doctors around utilizing this service. And so the service doesn't cover those places. So it's not something that we mandate across the system. And then when you look at system managers, the overwhelming feedback was that we can't do our business in Western New South Wales without this service. From patients' perspective, then there's two areas. So one is that patients see it as a really positive service. It was excellent. It was a way of being able to supplement their care and felt that they got everything they needed from the service. There was another group that would rather see doctors in person, but recognize that this service was able to meet their care needs. And so a lot of people, whilst they would say they want to see a doctor in person, when we interviewed them and said, well, is there something that you didn't get from this service that you would have from the face-to-face doctor? They said, no, I've gotten my care needs met. It was a preference of seeing face-to-face, which is understandable and what we expected as well. There were no patients that were interviewed by our team that said that this service was unable to meet their care needs. When we look at scalability of the service, there are, from a cost consequence analysis, the price of the service per NWOW versus face-to-face care, there are savings there, as well as cost per ED encounter and the inpatient encounter. So that graph on the right. This overall, when I look at this, what a lot of people that are very cautious around this will say, see, I told you so, this is a cost-saving thing and you want to get rid of every doctor. This service only covers a little less than a third of the total activity across Western New South Wales. And my net cost in terms of the amount of money I've been spending on doctors is actually increasing since we implemented this service. But what it allows us to do is be able to pay our doctors on the ground well and competitively, but also look at a number of other innovations that can support rural communities. And so despite us being a state-based organisation, we're starting to actually run primary care clinics, which we're not funded for. And through some of these efficiencies, we are able to look at how can we better service the community. So when I look at some of these components from an evaluation perspective, particularly virtual clinical pharmacy service and VRGS, we've mapped a lot of our outcomes to some work that I've been doing at a state level around monitoring and evaluation of virtual care. And this is one of the main components of our M&E framework for virtual care across the state. Essentially, it's all aligned around the quadruple aim, that sort of greeny colour groups at the top, but looking at our outputs and foundational activities that we've mapped against our strategic plan for the state. And one of the things that I do say to clinicians is that we need to think very early in the design of new models of care around how we're going to evaluate, because often our systems, even with this VRGS work, there was a huge amount of manual linking, coding, huge amounts. huge amounts for the team to be able to, one, find the patients, let alone cohort them as, has this patient only seen a VRGS doctor, or have they seen a VRGS doctor and a face-to-face doctor, or have they only seen a face-to-face doctor? Because there's no flag in the system that says this was a virtual appointment or not. The doctor's right in the same EMR system as if they were face-to-face, and there is no way of doing that. So cross-referencing rosters with names of people that are writing notes with a whole host of other factors allowed us to split up the cohorts. Huge amount of work. The last case that I'll share with you, and then we should have some time for Q&A, is just our vCare unit in Western New South Wales. And to save you from hearing me blab on, I'll put a video. Hopefully you can hear this. Yes or no? Maybe not. Let me pause. Let me find. Just bear with us. There's a thing I have to tick to say it is going to share my sound.
I think that might be when you share, but we can actually read the captions if they're throughout.
Yeah, hopefully. Just give me one moment. I'll just check. There we are. So let's try. Is that sound coming?
G'day, I'm Scott, the Chief Executive of Western New South Wales Local Health District. We've got a stunning region to live and work in. A region that's over 280,000 square kilometres, the size of England, with over 280,000 people that live and work in this beautiful region. We now have a network of 38 hospitals and health services. That means that we've got a fantastic opportunity to bring care closer to home for patients. Now, our real challenge in this is to make sure that the quality and standard of care is something we don't compromise on.
vCare in Western New South Wales was established to be able to support our rural and remote health professionals in providing a service that ensures that patients, regardless of how unwell or how remote they are going to get the same standard of care that you could get possibly in Royal North Shore in Sydney or Royal Prince Alfred, ensuring that our patients across this region are going to get optimal outcomes moving forward.
We provide a clinical advice and support service to the Western Local Health District hospitals for patients that live in rural areas that don't have specialist care in those towns. We use a range of technology and system enablers to help us have eyes and ears in the room.
We get incredibly unwell patients and people who have been in motor vehicle accidents that need a really high level of care, and we can provide an intensive care level in our emergency department with the support of vCare. So with a doctor on the camera guiding our small team of doctors and nurses, we can run an intensive care in our ED that transitions onto the helicopter, that transitions into the base hospital ICU, and that person doesn't have a delay in their care just because they've had their accident in the bush.
So the vCare team consists of a number of people. We have registered nurses, we have critical care specialists, we've got dispatch coordinators and other support staff. We've also got a non-emergency team, and we also work very closely with a number of other specialists across the district and in tertiary facilities that also come into the conference.
It provides you with that backup support. So I'm very aware that staff are at times extremely time poor. They're balancing jobs, trying to prioritise. So it actually allows us to have that off-site backup, so someone else is watching what's happening with your patients. It's made a big impact in terms of who's supporting us.
So an example of a patient journey through vCare, a gentleman presented to COBA ED with 9 out of 10 central chest pain. They identified that that man was having a severe heart attack. They called the single point of contact for vCare. The nurse prioritised that phone call as a life-threatening referral and invited a number of medical specialists to that phone call, including a cardiologist.
They noticed that he was having a significant heart attack, and again the cardiologist also linked in with vCare to support the teams on the ground.
They were able to execute a management plan for that patient, and he received clot-busting medication, and we moved him with an emergency transport resource to the best location to meet his needs.
This gentleman, within 7 minutes of presenting to a hospital, received life-saving treatment.
We have the staff 24/7 available to respond, to coordinate some of the best specialists, both in our region and across the whole of the country.
If vCare wasn't around in that situation, he possibly could have died because he was hundreds of kilometres from a specialist.
Virtual medicine is not new to us. What we're doing with the virtual care unit is continuing to innovate.
Our absolute dream and vision is to help people be healthier and for our communities to thrive. With the cutting-edge technology and the new ways of working, this is our time to make a real impact, to connect people to something they can feel confident in and to make an impact in their lives.
Not sure whether the sound actually came through to you or not, but it did. Great, fantastic. So that's a little bit of vCare unit, which is essentially a 24/7 critical care unit that supports emergency advice and logistics for across our region. And this, so like VRGS, this service is being requested across New South Wales and will likely pick up and support a number of other LHDs in our region. VRGS, I should have said in the previous case, has actually expanded into southern New South Wales and is supporting the southern New South Wales rural and remote sites. So ignore that blue box on the side. That's very old now. Essentially, one of the key components that we recognised with vCare was that we were hindered by the fact that for vCare to be able to provide advice to sites, the site needed to recognise they needed help. And that sounds like an obvious thing. But when we reviewed some of our serious incidents across the region, across a number of years, one theme probably stood out most amongst all of them. And that theme was failure to recognise or intervene when a patient was clinically deteriorating. So either people didn't recognise that the patient was deteriorating to the degree that they were, or they recognised it, but they didn't intervene in a timely manner. And a number of times by the time vCare got involved, the patient was so sick that there wasn't much choice but to implement or activate a retrieval unit. And so a number of years ago, we implemented a remote inpatient monitoring system, which is in addition to a lot of the safety mechanisms that exist in contemporary hospitals. But essentially, it's a remote monitoring program that every patient in our small rural and remote sites will be monitored. And so this system, which is a Philips system, I'm not being paid by Philips, it just happens to be Philips, so I've put their name there. This system pulls out of our electronic records already recorded patient data. So things like patient observations, their pathology, those type of things. And it goes into sophisticated algorithms. They call it AI. It's not really AI. It's just an algorithm-based platform that helps us monitor changes in terms of patient outcomes and some of their biometrics. It provides us with early warning scores to allow us to intervene in a proactive manner. And it also provides us with static alerts. So if someone's blood pressure just by itself goes up, but that doesn't actually push their early warning score up, we'll get that alert as well. So there's quite a fair bit of information within this system that we are able to utilize to be able to allow our emergency nurses or our emergency specialists or our VRGS teams to intervene and provide help. The other thing that this service allows us to do is to provide what we call reach, which is essentially family activated escalation of care. So where families feel like they're not being listened to, or that their loved ones' care isn't the way they think it is, they can actually escalate through to this unit to be able to get a third party having a look with fresh eyes at the patient. So some of the components of vCare, they get 60 to 80 patient flow calls a day in terms of transport logistics, and a number of those are clinical requests for help. Priority A calls are the sickest of the sick patients that we have across the region, and there's usually around 4 to 5 of those a day on average. Some of those calls can last 2 or 3 hours while we're waiting for retrieval to arrive. They coordinate 30 to 50 non-emergency transfers a day. They have 15 crews traveling over 4,000 kilometres a day, moving patients around the place. Our doctors do over 30 medical interventions a day. There's 15 ambulance emergency transfers coordinated through this unit a day. That's from our hospitals to another. 6 aerial transfers, and they do daily huddles around patient flow for the facilities, understanding where beds are, looking at the larger facilities, trying to facilitate people getting close to home and flow out of our large centres so that we can flow patients in there as well. So that is all I had to share today. I just wanted to share a few models, and essentially when I talk about virtual care, a lot of people go, well, how do we actually implement our own? And like with any new model of care, you need to be able to have a very thorough project approach in my mind. There needs to be clinicians as well as administrators, as well as researchers, as well as tech people in the room talking from their respective spheres about risks and benefits and where they can come together to co-design a model of care. The teams that are leading the design need to really understand what is evidence-based, and unfortunately there isn't a huge amount. It's growing, but there isn't a huge amount of what works and what doesn't purely in the virtual space, but there is a huge amount that is written in terms of face-to-face care. And so if we utilize what's best practice in face-to-face care and try and translate that into a virtual environment, we should get as close to what is best practice as possible. And then the other thing that I would say that is really important that I haven't already is that when you truly have a virtual team, so not a team that comes together in an office providing virtual care, because that team is actually not virtual, they're actually face-to-face together. So they do get that human interaction of, I'm going to catch up and ask Kate how her weekend was while we're having a cup of tea, or those type of things. You really need to think about where you have dispersed teams across geography. So for VRGS, we have our doctors all across Australia and a number of doctors overseas. And one of the key things that we identified very early was that we wanted to make sure that this team felt like a team, despite being hundreds or thousands of kilometres apart. And with some of the feedback that we had actually through some of that research was that the actual VRGS team felt that the VRGS team was more collegiate than their face-to-face work elsewhere. And we put in a number of ways to do that. Some of that is face-to-face training twice a year where we bring them together, which has a not insignificant social program for it. And it's not a jaunt for doctors to just have fun. The point is that some of that just interaction between the team where we're not having to do work-based stuff is completely invaluable for us moving forward. You can see the engagement of the doctors lift after those face-to-faces. They start doing proactively, starting to look at how we can improve systems and care. And we really get a lot from our doctors when we support them through feeling like they're a team and that they know one another. And you see, we use a number of channels to allow them to talk amongst themselves while they're all on shift, because there's multiple doctors on shift at a time, to help coordinate the way that they're providing care. Ask each other questions, or ask the group of the broader VRGS group questions about, hey, I've got this really tricky case, what do you think? But also when you look at that, there is not an insignificant amount of people sharing photos of their families, what stuff that they've done on the weekends, asking people, oh, how's the kids? I thought your eldest had their high school graduation last week. How'd that go? So that is incredibly important in building a team, particularly when they're geographically spread apart. I've talked enough. I'm happy to take any questions from the group if there's time. Otherwise, happy to leave you to your Friday afternoons.
Oh, thank you so much, Shannon. It was excellent and lots of really relevant things to what we're trying to do in Deliver. So I think we've got like a couple of minutes for questions if there are a couple of key ones. And I think no doubt we'll be in touch to learn more of your learnings. But yeah, just opening it up if anyone wants to unmute or pop their hand up. Anna.
Hey, thanks, Shannon, for those cases. You've got some great work going in New South Wales. And I hear what you're saying about that data linkage. That sounds like it was a nightmare, so well done on that. I'd be really keen if you've got any evaluations available for either the pharmacy and the VRGS, whatever that was, program that you can make available to us, or that might be coming out soon.
I can email Kate what's already published and publicly available. The VRGS evaluation is in the process of finalising. It's a big evaluation. That'll be made public. Yeah. There's a sort of 200-ish pages that I'm slowly reading from front to back before we publish it. But we've just been working with MJA, and there's likely going to be a 7-paper supplement to the Medical Journal of Australia that we hope to have published next year. So that's the aim. That's specifically to VRGS. The Virtual Clinical Pharmacy Service, there are a number of papers already published. The main outcomes paper, we're just doing the backwards and forwards with the journal at the moment. So that's looking promising. So we hope to have that published soon. The vCare component, there's some more descriptive studies written up about that. I'm just about to commission an evaluation on the patient monitoring program that I mentioned in my talk, and that should be done by, all going well, March next year, at the latest June next year. So there's a fair bit of stuff coming forward in this space.
Yeah, fantastic. Thank you. Look forward to reading those. Hey, I have a few questions. Can I nick in before Anna Peter starts? So just in terms of the VRGS, I was really interested, we've got the face-to-face program and it's having trouble getting off the ground in Victoria. Of course, we've got a slightly different system. So I'm really interested how those doctors are employed. It sounds like a different setup, because normally they have to be employed through the hospitals.
Yeah, so the hospital, the doctors are employed by our district. They're actually employed as VMOs, so they're technically not employees, but we pay them. So they're contractors on essentially 0-hour contracts, but we provide them with contracts that they give us reassurances of minimal commitment, because if everyone gets to sign a 0-hour contract, then each month no one has to turn up to any shifts, and that's highly problematic. And so we've got minimum standards expected of the service. So some of that's the face-to-face time, some of that is minimum shift time, commitment to team meetings, quality improvement, and those type of things. And when doctors aren't meeting that, we have a very low threshold for performance managing them. So unlike a lot of rural communities where if you've got a doctor that's not towing the line completely, a lot of people put up with it because they know if you get rid of that doctor, or if they get cranky and leave that little town, then you're likely not going to have any doctor for years potentially. Whereas with this service, I know if I performance manage a doctor and we get to a point where they or we or both say this is not the right fit for whatever party, I can replace them pretty easily, like very easily. Yeah.
That sounds like an amazing system where you've got some accountability. So obviously you're not having problems with recruitment, because I think we're having even problems recruiting into our training program.
Yeah, so for VRGS, we don't have problems with recruitment. On the ground, we have huge problems with recruitment. Huge. So I've got rolling ads for some of our towns that I have not had an applicant for 3 or 4 years. Rolling ads. For VRGS, when I advertise, I can advertise for a week because I might think I've only need two doctors. I could advertise for a week and have 20 or 30 applicants, and advertise through government-based sort of recruitment platforms that no doctor actually looks at. So it's completely word of mouth. When we first started the service, we did cast a wide net. We spent some money around getting this in, so social media, advertising, and that type of thing. And when we first ran it, we ran with a recruitment campaign of a month, open for a month. And we had nearly 50, I think it was like 54, around 50 to 55 applicants apply. Unheard of for us.
Yeah.
And all of them, every doctor I would have employed if they were applying for a face-to-face job. So our bar for the service is so much higher. We reject very good doctors on this service. And the doctors, some of them get quite cranky because they've never been rejected from an interview before. But our bar is much, much higher for a doctor to enter the service compared to on the ground, because unfortunately on the ground, we literally don't have anyone applying for a lot of jobs. Yeah.
Right. So, and sorry, I'm hogging the table, but so the VRGS, obviously they can live anywhere and they can provide that service. So that's the beauty of it in some ways, but they still have to be accredited as rural generalists. Yeah.
So they have to be credentialed as a doctor. So they have to go through the credentialing hoops the same way as a doctor face-to-face. So we had some negative media in the early days because we had a doctor who is actually a professor of rural and remote medicine who was an Australian of the Year candidate, like very well known. He's actually a consultant for the World Health Organization, happens to live in Switzerland. And a patient heard that there was a doctor providing care from Switzerland, and the papers ran with a story that Western New South Wales are employing Swiss doctors to provide care, and how do we know that he's actually an Australian doctor? And luckily they didn't know who he was because they'd be very embarrassed. But if we shared publicly who that doctor was, there'd be no question about that guy's commitment to rural and remote medicine or his credentials. And so that's where the other piece that I didn't mention is the media aspect of this, because there are a minority, but usually a vocal minority, of generally older rural GPs who see this as a complete threat to the way in which their livelihoods have been raised. And I get it, because a lot of them don't trust state government. They have got bad relationships with state health authorities. And so why would they trust an organisation to be trying to do the best by rural communities when they feel that over decades they've been hard done by. And so when you do start, particularly services like VRGS, they feel like, oh, this is just one step down a slippery slope to getting rid of doctors and communities. And so that's where, for us, the real importance of the VRGS doctors doing face-to-face care, and also choosing doctors that have credibility in rural and remote communities is incredibly important. Because if all we need is one doctor that goes, oh, you're in Cobar, just get your surgical consultant to come and see the patient, you lose credibility incredibly quickly from the nursing staff and the patients themselves.
I'm going to interrupt there because we are a bit over time, but no, thanks so much for the questions, Anna and Shannon, for your time. I'm sure if there are other questions, you feel free to email me and I'll forward them on to Shannon and get a response back to you. But thanks again, Shannon, for your time. And yeah, I really will be in touch to learn more from what you're doing up there in Western New South Wales. It's amazing.
Thank you. Thanks, everybody.
Thanks so much. That was great.
Thank you.